I realized this morning, Electra, we're related in more than one way. I think we're both 15-year survivors. And so this work in lymphedema began soon after my journey as a breast cancer survivor began. And today, in this next 45 minutes, I just want to share with you some of the things that we found from the NIH-funded study that we have. And as we move through that, then I'll come to where I want to give you a look at where we're headed, at some of the exciting projects that are on the forefront in terms of research in lymphedema, breast cancer, and other areas. We've had a very good background established this morning and this afternoon in what the impact of breast cancer lymphedema is and the impact of lymphedema in other patients with cancer and lymphedema of other causes. We know that breast cancer survivors are at lifetime risk of developing lymphedema, that its emergence is related to some aspects of treatment in most cases. Compared to women without lymphedema, those with lymphedema after breast cancer treatment have been found to have lower physical and mental health-related quality of life. Previous studies show that problem solving is a significant predictor of psychological distress among cancer patients. The experience of lymphedema, we find, is very individualized. It's variable as related to when it might emerge. Does it emerge soon after treatment, soon after their diagnosis with breast cancer, or decades later? Does it emerge with a significant event that someone can point to, or is it insidious and it just gradually emerges and becomes an issue? So there's not only the time since diagnosis and how it emerges, there's also observed the issue of the duration of the lymphedema episode. It can be transient, it can become chronic, it may be a state that swelling comes and goes and then eventually becomes chronic. It may happen once and go away and not appear again during that lifetime. So there's a difference in the pattern. So people experience a difference in frequency of limb volume change and perhaps symptoms related to that. There's a concept that we could have of our overall period of time spent with lymphedema. Is it a small amount of time? Is it a small amount of volume that is affected in our arm, a small amount of distress that we experience? But particularly with this aspect, we're looking at, is it something that came and lasted for a long period of our survivorship, or is it something that came and went and is just a memory because it was very transient, that maybe took care of itself, maybe was taken care of with treatment and then with self-management after that and didn't ever pose another problem? We know that many clinical settings and most research studies that look at lymphedema have measurement data for patients, but they often use different protocols. They do use different approaches, as was pointed out this morning by Mike, in that they may use water displacement, circumferences, perimetry, electrical impedance, with symptom assessment. So there are different ways that lymphedema is measured, or as Dr. Cormier pointed out, sometimes it's simply visible swelling is all that's reported in that study that is talking about lymphedema and its impact on patients or its prevalence of occurrence. These discrepancies among reported percentages of lymphedema stem from difficulties in measurement, different standards of diagnoses, and different periods of follow-up. Here we have that picture of the horizontal parameter. As Mike said, I'd probably have one. It's a picture from our lab with some of our staff. And here is a picture of the circumference, the way that we do it with the 4-centimeter increments. So we have limited research in analyzing trends of lymphedema changes with patient profiles. We have limited evidence-based recommendations regarding limb volume changes, how to prevent it or reduce the risk for it, how to manage it in the short term and the long term. And then we have limited evidence-based recommendations from the trends that occur with lymphedema occurrence and changes. Recognition of the characteristics, the trajectories that may occur, the ability to quantify our period of time spent with lymphedema, both by volume, severity, and the amount of time we spend with that swollen limb, give us an opportunity to really look more in a more refined way at the impact of lymphedema, both in functional ways and in psychological or psychosocial quality of life issues. So here I have 4 bullets that I've organized some findings I want to share with you from this decade of work that we've done that's been NIH funded. I'll move through these 4 with brief reports in that area, and then come to where we're moving ahead with the next study questions. This model has guided our work from the beginning, thinking about what the predisposing factors are, which might be treatment-related factors or family history of lymphedema. It might be our BMI at the time of diagnosis or at the time of trauma. The factors that we have thought from the literature and from the early research that's been done that may make an individual predisposed to the development of lymphedema, in our case, particularly after breast cancer. Over on the left side, you see what are theorized to be the protective mechanisms, the way we cope with problems that have occurred early in our lives with our problem-solving skills and our social support. So not only how we deal with the breast cancer diagnosis, but how we deal with the emergence of lymphedema or the risk of lymphedema. In the middle there, you see the individual experience of lymphedema, the limb volume change, the symptoms that one experiences, and then how one copes with it and manages the symptoms when lymphedema occurs. On the right side, you'll see the psychosocial adjustment, overall quality of life, and functional health status, which are the treatment outcomes. Those are the indicators that we want to look at to see what the total impact is on the person of living with lymphedema. So the first of the problems that we're going to think about are the lymphedema occurrence over 5 years after breast cancer diagnosis. So looking at 60-month data from the time of the diagnosis before lymphedema would have occurred and over the months of treatment. This particular set of data that I'm going to show you are based on a subset of our data where women were enrolled before surgery. So we have those baseline measurements followed post-op every 3 months and then every 6 months thereafter until they reach 60 months. This timeline shows the annual points at which our psychological data are collected, and in between we do the visits with circumference and perimetry as well. Our patients average age 57. They range from the 20s till in the 90s. The surgeries that they've underwent are here, with about half undergoing mastectomy, 60% have undergone chemotherapy, half have undergone radiation, and then the axillary staging is shown here with 43% with sentinel lymph node biopsy and 30% with axillary lymph node dissection at the time that they were treated. 11% had both procedures done. Here again is the perimeter, one of our objective measures that was used in our study from the beginning. We were the first site to use the perimeter that was actually developed for the fitting of garments in a very accurate way. We were one of the first ones to use it in a clinical setting for research to try to assess very accurately limb volume in a more precise way perhaps than we could with circumferences. Throughout our studies, we've always used perimetry. We've used circumferences with a 4-centimeter girth, and we've also assessed symptoms. We have 19 symptoms that we assessed with this LBCQ tool. We found early on in the first cross-sectional study that we did, swelling and heaviness were particularly predictive of a 2-centimeter change in girth. So in this analysis I show you, we focus out of all those symptoms on swelling and heaviness by self-report. The 4 criteria that we use in our analysis regularly are the 2-centimeter girth change, a 200 milliliter volume change from before surgery or compared to the other limb, a 10% perimetry limb volume change, and then a self-report of heaviness and swelling now or in the last year. This shows us for 60 months where everyone begins with no lymphedema, and then where they progress at the end of 60 months with meeting the lymphedema criteria at least once. That becomes important in a survival analysis. Once they meet the criteria, they meet the criteria. We don't take that diagnosis away if they have reduced in volume at the next visit. So when we look at the different definitions or the criteria for lymphedema, we see quite a wide range from 43% to 94% have met that lymphedema criteria at least once. I'm going to show you now in the number table so that you can follow with the numbers from 12 months through 60 months. The 2 centimeters is at the top, 200 milliliters, then 10% volume change, those 2 by perimetry, and then the signs and symptoms of heaviness and swelling. So you see over the 60 months, from 12 months You could have a low of 22% meeting a criteria, or 32%, up to at 60 months, 83 to 94% meeting that criteria, with the more conservative criteria being symptom report and 10% volume change, and the most liberal criteria being 2 centimeter at some anatomic point compared to a prior measurement or at baseline, and a 200 milliliter limb volume change. This slide says so much in terms of why there's such discrepancy in the literature in our occurrence of lymphedema, in this case after breast cancer, because it depends on when you measure, how you measure, and how long you follow in terms of what percentages you get. Keep in mind, this is the same cohort of people that are being followed. So depending on whether we would have reported at 12 months or 6 months, or whether we're reporting at 60 months or 10 years out, we get different percentages of meeting that criteria. The other thing that's going to be really important with the next point that I make is that people don't always meet that criteria. This is sufficient for a lymphedema diagnosis, but if they go for treatment or if they have transient edema, then it may return to a near normal volume or near normal girth or an absence of symptoms. But this tells us that people met that criteria at least once in the trajectory. So at 60 months, 43 to 94% have met one of the criteria, 2% or 2 centimeter being the highest estimation method, and signs and symptoms the lowest. Now this is important. This was important for us to point out to NIH to get our next set of funding, and it's important for providers and for payers to understand. From 12 to 36 months, the rate, the identification of meeting the lymphedema criteria increased by 7 to 26%, so between the first year and the third year, and then between the third year and the fifth year, by 60 months, it's continued to increase at a slower rate, but 4 to 17% continued to meet a new criteria, meet a criteria for the first time. So that's really important to understand, that the risk isn't over at 6 months or 12 months, but it does continue, but at a slower rate of risk, and it is a lifetime risk, as the American Cancer Society tells us. I'm going to move to the next about looking at the patterns. So looking at those periods of time that we spend in that lymphedema state. And this is again using the 60-month data. It's looking at those 4 criteria. And I'm particularly going to talk about 10% volume change and then give you an example with symptoms to show you the same patterns are there. So in the survival analysis, if someone meets the criteria for lymphedema, they always meet it. That's what is the assumption of the survival analysis. Just like if I have breast cancer and I'm cancer-free, I still have a diagnosis of breast cancer. I don't lose that diagnosis. Now, when we look at the area under the curve, we're looking at the time spent with lymphedema. So we're looking at it in a different way, quantifying that experience to some extent. So our statistician worked with us in understanding the concept that we were trying to analyze. So at every visit, when we saw them from pre-op on, post-op every 3 months for a year, then every 6 months, we assigned a 0 or a 1 as to whether they met the criteria at that visit. They, if they had a 1, they did meet it under the survival analysis. But in this case, we gave them a 0 if they never met the criteria or if they didn't meet it the next time they came. So everyone has a series of 0s and 1s to give us an idea of their time spent with lymphedema as they came to see us. Now, there are a couple slides here that have a lot of numbers on them, and I'll just try to move smoothly through those. This simply tells us that 50% of people had 8 or more visits when we did this analysis. They had come to see us 8 or more times. When you enroll people over time, you have a different number of visits per person because some enrolled in 2000 and some enrolled in 2003. So this shows us that when we froze the data, 50% or more had been to see us 8 or more times, 8 to 13 times. This line, the darker line, the 1 spike line, is what I draw your attention to. So this, under each of those 4 criteria, at this point in time when the data were frozen, that many people had a single spike. That meant their volume went up to meet that criteria for lymphedema, and it never went down. So that's important to remember. They developed lymphedema, and they never did not meet that criteria. So if they had a swollen limb, if they had symptoms, if they had the girth change or the volume change, they never went back to the normal. They stayed with the spike. So that the one spike means that the top line is they either didn't have a spike or they came back down from the spike. They had a change that wasn't staying at the spike. Now here I've circled a couple of squares I want to explain to you, looking particularly at 200 milliliters difference at 0 and 1. The 0, that 34%, did not meet that criteria. They never had the spike that met the criteria. The 1 means they did meet the criteria and they didn't return to normal. But down there at 5, 6, 7, those 8 people had 5, 6, or 7 occurrences of spikes. Now that's a very interesting set of people that are going up and down in their volume change. So they're the people with this pattern of one time meeting the criteria, the next time not, the next time meeting it. Now is that more distressing than having a stage of lymphedema that's stable? I think that's a question that no one has looked at. On this slide, I'll point out that the top row where that circle sits, these are the number of people that never met that particular criteria in this frozen data set. So out of the 193 that we had perimetry volume on at that time, 68 or 35% never met the criteria of 200 milliliters. So this slide simply displays how many times they met the criteria when they came to see us. It's simply an array of that data. What I think is the most interesting are the patterns that we see. So on the left side, on your left side, we'll see a picture of one spike for lymphedema at the 10% limb volume change. That's particularly what is on this slide. So you can see that spike may have happened early, as the top one is, or it may have happened later. It may have lasted for multiple visits, or it may have only been a single visit. So with only one spike, it's still a different story for different people. It could be a short period of time with lymphedema, transient. They maybe went for treatment, maybe were fitted with a garment, and they have no more meeting of that criteria. The first picture, they met that criteria for some visits and then didn't meet it for subsequent visits. So that's an interesting pattern that we know is among the patients that we followed. Now on the right side, looking at 10% limb volume change, we see 5 or more changes in those two, but they're different pictures because one has more what we call area under the curve or more time in lymphedema. The spikes are up and down, but they're broader periods of time. They're more days that passed with lymphedema, but it did go back to where it didn't meet the lymphedema criteria at 10% volume change, and then it recurred again. So it's an up and a down of limb volume change. The second one there on the right side is later in their cancer survivorship trajectory and briefer periods of time. So that's interesting to delve into what has happened here. Did someone have infection? Were they hospitalized? Were they traveling? Did something happen in their lives? What's accounting for these different patterns, and how does that affect the person's function and psychological distress to be going through these different experiences in different time? Now, just to show you it's possible to look at these patterns with not only 10% volume change, these are reports of symptoms of heaviness and swelling on these panels. So here on the left upper is 5 differences in reports of symptoms that people experienced, particularly heaviness and swelling. So they didn't consistently report that every visit, but some visits did and some visits didn't. And is there more distress, when there's an extended period of time with those symptoms? We don't know the answer to that yet. The other 3 frames that show symptom report show early report of symptoms, like in the lower left, later report of symptoms there in the upper right, and then a prolonged period with a slightly different area under the curve in the lower right corner. So just to show you that's a very individual experience, and our next steps are to look at our quality of life, our functional status, looking at the various patterns of the lymphedema occurrence, which has not been done before. We think that may give us insight into the true impact of lymphedema, help us to know earlier where we can intervene to maintain a constant state with lower limb volume. I think it'll be very informative to us and a novel way of looking at this. The third novel approach that we've taken builds on what Dr. Stewart told us about the data mining approaches. and ways of looking at patients at risk, and it really follows up on the question from the audience about going forward with using the minimum data set information from more than one study site. My caution to you is that this data comes from the University of Missouri Ellis Fischel Cancer Center, our ways of measuring our group of patients, and these measures need to be looked at across multiple sites so that we have confidence that these are patterns or trends across data for breast cancer survivors and then for other survivors of other cancers or trauma or primary lymphedema. In this set, we use the perimetry volume again, particularly. These are the time points when our data are collected. And here we used as a boundary measure, we set 5% limb volume change as a volume that we wanted to follow, even though 10% limb volume change is the criteria that we've used for looking at lymphedema. Here we said if there was a change by 5%, either a decrease, the arrow down, a stable, or an increase, the arrow up. That's what we were going to follow at each of those visits for the first 30 months of their following. 10% volume change was the lymphedema criteria, but we were looking at changes in limb volume in the individual at 5% change. So at the time this data set was frozen, 216 patients were in the 30-month study. 69 of the 216 had met the lymphedema criteria by 10% volume change. So then it was fed into the temporal mining framework for the data mining process. And these are 3 examples of patterns from, again, the caution is from our data set, preliminarily before people had finished 60 months, but looking at the first 30 months. So here, if the volume was stable at post-op, which is T1, stable at 3 months and at 6 months, when we looked out to 30 months, 20% of those people who had stable volume at those times, at 10% volume change, developed lymphedema. So 20% developed lymphedema later, sometime before 30 months, even though they were stable, not increasing by 5% at any of those earlier visits. They might have had little changes, but it didn't meet the 5% criteria. Now the lower one, if they were stable at post-op and stable at 3 months, but had 5% or more increase at 6 months, those people by 30 months had a 94% risk of developing lymphedema at 10% volume change. So here we look at kind of an ability to predict who we should monitor more closely, who should come back and be monitored. They haven't met a diagnostic criteria for lymphedema, but should they be brought in more frequently than the person who's stable at 6 months? That's the question to be examined clinically and by researchers in other data sets. So that's pattern 1. Pattern 2 was being stable at, again, this is a shorter time period, so we've just followed them now for 3 months and not to 6 months. So if they're stable at post-op in 3 months, we show a 30% risk of lymphedema within the 30-month period, a 30% risk. On the prior slide, we had data that went through 6 months. So 3 stable visits had only a 20% chance. Only 2 stable visits, we just have less information. So it's a 30% chance that they would have lymphedema within the 30 months. We don't know what's happening to them at 6 months. It's an unknown quantity when we look at that. Now the bottom row shows stable at post-op, not meeting a 5% criteria, but increasing at least 5% at 3 months. These people, where we only have data for 3 months, would have a 57% chance of developing a 10% limb volume change sometime during the upcoming 30 months after diagnosis. So there's a different pattern here, which may tell us that that 3 to 6 month or 3 to 9 month period is an important surveillance time based on this, one study with these small numbers. Now, the top row here has the stable and the increase at 3 months, just like in the pattern I showed you in pattern 2. But now we're going to look at pattern 3. If we have an increase at post-op, and a lot of people have normal post-op swelling, if we have an increase of at least 5% at post-op and another 5% at 3 months, as Dr. Stewart said, 5% plus 5% adds up to 10%. Well, in this model, in the temporal data mining model, that pattern of 5% increase and another 5% increase by 30 months, they meet a criteria of lymphedema, and that's because 5 plus 5 is 10. So that's an area that we need to be considered of post-op swelling. That isn't lymphedema, or it may not necessarily be lymphedema, but it may be a prompt to, again, watch this patient carefully to see what happens at 3 months and 6 months. So we see these various patterns, and my caution is that this is in a single study looking at 30-month data. We now have data that takes us through 7 years, and we'll be looking at the patterns as they advance through that period of time and looking at patterns in other data sets that use similar measures to ours, perhaps to be able to look in Dr. Cormier's data set with melanoma. Do we see similar patterns with melanoma patients who have post-op swelling and have swelling at even a 5% level after treatment? The fourth area that I want to cover just in a few minutes, because psychosocial issues are so neglected in our research. We ask every year, annually, we ask our patients from post-op through every annual anniversary to complete a psychosocial tool. We actually give it to them in a mailback envelope and they send it back to us. So we have psychosocial data at their anniversaries that we've been able to look at in terms of problem solving and overall quality of life, functional health status in that period of time. So here we have had, in this frozen data set, 337 have completed those surveys for this period of time for us by mail back. The reason this number is larger here is that we began enrolling people at pre-op in our R01 study, and we later added a cohort to be brought in at post-op within the month post-op because patients were asking to join the study to be followed for lymphedema. So we have 2 cohorts, but everyone gets the psychosocial tools at post-op, so we can bring those 2 cohorts together for this particular analysis. Again, the mean age was 57 years because this is the same group that we recruited. This is the psychosocial model that we have followed throughout, but now we're looking at problem solving, coping effectiveness, and the outcomes of psychosocial adjustment, overall quality of life, and functional health status. These are the tools that we chose to use. We use a problem-solving inventory called the PSI. We specialized or focused a coping efficacy tool on lymphedema coping, and we call it the Coping Efficacy with Lymphedema, the CEL. Psychological Adjustment to Illness Scale Self-Report, the PACE self-report, is adjustment to chronic illness, a tool that's used across cancer but also other chronic diseases. The Global Severity Index is a report of distress with symptoms that one experiences, and then the FLIC, a Functional Living Index for cancer, is a specific quality of life tool for cancer. So those are the tools that are answered by our patients every year throughout the following time with us. And I changed the order of these slides from your handout so you can see patterns. So as I flash through them, the 4 number slides are all together here, and then I'll summarize them. You've got a number slide with a word summary and a number slide, but I wanted you to visualize the changes. This is at 1 year, the correlations with the stars being the significant, the asterisks are the significant relationships, and I made them light blue. So this is year 1. Now watch what happens at year 2. The pattern changes a little bit at year 2. Here's year 3, another pattern, and now I've jumped to year 5. So the pattern is a little bit different again. And what the word slides will tell you that I've got here together, I'm going to come to the summary. The word slides will tell you the patterns of relationships between problem solving and social support, which is what we begin the cancer experience with, and the coping with lymphedema, which occurs if we develop lymphedema, and those outcomes of psychosocial adjustment to chronic illness, the quality of life. Those relationships change, and the place that the protective mechanisms of problem solving have the greatest impact are at that period of post-op to 12 months. The relationships are the strongest across those outcome measures at 12 months. So that may be a message to us to target enhancing the problem-solving skills of our patients in that time at post-op and helping them prepare for how they would cope with not only the cancer but with lymphedema symptoms or limb volume swelling. Once we pass the 12-month period, there's less strong correlation between those variables, and maybe our ways of coping are more established or more set and less amenable to intervention. So that's a really important takeaway message in looking at the longitudinal data. The other point that I would say that's an important one is that of the problem-solving inventory, that of the belief that we have the ability to change things, the personal control, that's the most significant correlating variable out of the problem-solving inventory. So that personal control that one has going into this crisis experience of breast cancer and then of dealing with lymphedema, that may be a very important skill to enhance the active coping rather than avoidant coping. That's an important skill that may be very useful in having a less distressed outcome at 12, 24, 36, 60 months later. So that, in a burst of words, was what we've learned, some of the lessons we've learned from actually it's been 7 years of following patients, and some of them are approaching 10 years that we have followed them because we began in 2000. But I want to build on what Mike shared with us about the genetics as looking at the next questions. We've had some pilot funding to allow us to invite the women that we're following in the breast cancer study. They're all women, but 3 men in the breast cancer study. We've invited them to supply buccal swabs and salivary specimens so that we could do a GWAS test or genome-wide association study so that we could examine the same gene mutations that are seen in primary lymphedema and also examine new mutations that might occur in secondary lymphedema. So we've had funding to process 96 of those. They're $420 a piece to process. So that's why we have to do this slowly. We've collected specimens, but we've processed the first 96, and we have bought the supplies for the second 96 and have specimens stored. But we're looking at novel and known genetic mutations that we may be able to find associations with the development of lymphedema. One of the complexities of this is that it's clear from the data that there are different phenotypes of lymphedema. Primary and secondary have differences. Melanoma and breast cancer may have differences. Lymphedema after trauma or knee surgery may be somewhat different. But even within a diagnostic classification, lymphedema presents differently. It may be mild or severe. It may occur early or late. It may be stable or transient or recurrent. So we have different patterns there, and that's going to be one of the challenges. It may be different genetic mutations are responsible for different phenotypes. So that's something we have yet to learn. This is a picture of our GWAS of a plate. We use the Illumina platform, and that work is ongoing. The other exciting aspect of the genetic studies that we do is that we can collaborate across funding and across sites. And we've been able to form a partnership with the Nurses' Health Study at Brigham and Women's at Harvard, where tens of thousands of nurses have been followed for decades. Some of the nurses in this room may be in that study. I've been in there since I was a young nurse. There's one back there that raised her hand. So among those tens of thousands of nurses, many have developed breast cancer because it's a female population by and large. And so 5,000 of those nurses who developed breast cancer were GWASed, had this genome-wide association study done. And that data, being funded by NIH, is available for collaborative studies. We've been accepted as a partner to this study, and we've been allowed to survey the nurses who, with breast cancer, were GWASed in that 5,000 set. We surveyed them by mail to report back to us if they've been diagnosed with lymphedema or if they've had symptoms of heaviness and swelling. So the first wave went out in 2010. They entered the data in the summer, so it was entered last summer. The second wave went out in 2011, so that data is being entered this summer. And we'll be able to query then the GWAS archive data set to see what matches the report of lymphedema by nurses who are very good reporters. So we feel quite confident that even though we can't measure these nurses, we will know if they have lymphedema or not, and we'll know their genetic makeup. So we'll be able to look for those novel genetic mutations, and we'll be able to look for those that are known to be associated with primary lymphedema. So I think this is going to be a really important finding. It's a process of, it's been about 3 years in the working through the partnership and now through the survey, but soon, I think in 2012 to 2013, we'll have a report from that work. We should have reached that point. Okay. Now this, Kyle from Solaris has left, but we've had a partnership with different people, including Solaris and Joan White at the Lymphedema Network out of Atlanta, the Lighthouse Lymphedema Network, to provide donated resources for South Africa for patients with lymphedema, for therapists that are treating patients. So I have here on this panel some of the global work that we've been associated with that's been a real privilege to be a part of. I had a small funded study that allowed me to interview traditional healers in South Africa about how they managed cancer symptoms and swelling among patients. So here's a little hut that is actually where the herbals and different botanicals are that are given to patients who have swelling or other symptoms that they go to the traditional healer for. We've published that in the Journal of Lymphedema. There's an article about that. We've also been the first, with using the Norton School curriculum, took a lymphedema training to South Africa. We've now trained 53 therapists there, so patients have access to people who've had the 135-hour training. So this is one of our training classes there. We've interviewed about the impact of breast cancer lymphedema. This has also been published. We've compared findings to these qualitative studies there, qualitative interviews there to ours in the United States. We've met with health payers there and presented about lymphedema and its impact and the importance of early intervention. And we have a policy summit coming up in March in Cape Town related to that. And we're working toward developing a lymphedema registry, which may put them ahead of other countries. When AIDS erupted in South Africa, they stopped keeping the cancer registry. So since 2003, they don't have accurate numbers on cancer because all the resources went to HIV and AIDS. But when we rebuild that cancer registry, our hope is they will be the first cancer registry that actually is monitoring lymphedema occurrence. So working with the public health ministry and therapists and working through the academic institutions with master's and PhD students, we hope to energize that effort there. And in our annual report, which will be on the website, we've got pictures of patients in South Africa and Ghana with the garments that were sent by the Lighthouse Lymphedema Network and Solaris. So you're welcome to look at those pictures and see some of the notes from our patients there. I don't have that slide here. I will wrap up by saying there is excitement on the front of the cooperative group trials in focusing on lymphedema. Electra shared with us about the 70305, which is, to our best knowledge, the first such cooperative group trial that is a randomized intervention to reduce risk of lymphedema, and this following breast cancer. That could be applied to other cancers as well. It could be generalized for interventions with other cancer groups and monitored in a similar way with very rigorous measurements. And in this next year, the enrollment should be complete, and 18 months after that, we'll have data that show the impact of exercise, education, and garment. That's very exciting and really a pioneering effort in this area in the cooperative group trials. On the heels of that, there's an ACOSOG, a surgical oncology trial that Dr. Cormier and myself and Dr. Stewart are involved in, and looking at axillary management in neoadjuvant chemotherapy patients, so patients who get chemotherapy before their surgery. But we've added the outcome of lymphedema development and quality of life and also a genetic component. So they're doing this big study and following cancer survivorship. And we've been able to add the component of lymphedema, quality of life, and genetics to that. So that's very exciting. It's received preliminary approval, and we're going through the finalization of the protocol. And it will be open to cancer centers across the country through the Alliance Cooperative Group Trial. And now this is one that Electra also mentioned, I believe, the gynecological group study. It's called the LEG study. At University of Missouri, we're investigators with this also, with Memorial Sloan Kettering and Rich Barakat is the lead there in New York. But we got NCI funding to unfold this protocol, which mirrors the prospective study we've done with breast cancer at Missouri and the melanoma study at MD Anderson, following LEG patients who have had any variety of gynecological cancer. So they have instituted with the training, those institutions that are following this will have therapists measure at pre-op the leg, assess symptoms, and follow at post-op and every 3 months, and then every 6 months, like our breast study has done, and for the first time recording across the cooperative group setting the occurrence of lymphedema as an epidemiological study in gynecological cancers. And we do believe, as Dr. Cormier's statistics showed, the lower extremity is especially vulnerable because of those hydrostatic forces, the pull of gravity. So we think we'll get very important data, again, to show payers, to help our therapists and clinicians to understand the risk that exists, and help us to guide interventions with women at risk of developing lymphedema after gynecological cancer. So this is very exciting. The training was completed in July, 3 sets of training around the country, and so soon the sites will be enrolling. And we'll see what we know in a couple of years from that. The other final point in future work, and a direction that we really are looking to go with our next proposal to NIH, is looking at survivorship as we age. You know, the cohort of women we followed for 10 years are aging in place. And so we know that there are comorbidities, there are medications for conditions other than their cancer treatment. There are maybe functional changes that are occurring with aging. Maybe they've lost their social support system that they had in the beginning. Their problem-solving skills may have evolved, may have improved or not. But to look at the impact of lymphedema in cancer survivorship as patients age will be really the next focus of our following this cohort that we began with in 2000 and involving other cancer survivors to enroll in that follow-up. So not only the Missouri cohort, but other sites that have similar patients interested in doing research. We're taking some of our assessments, like the psychosocial annual assessment, to be web-based, so patients don't have to necessarily be based at Missouri to be followed in that study for psychosocial outcomes. So that's kind of the next step, and an area that we see to be a big gap in the literature in looking at aging and survivorship, and particularly aging survivorship and lymphedema and other chronic treatment effects. This is a model that we'll use in the grant when we submit it. And I want to acknowledge the support we've received by NIH, by the University of Missouri, by Ellis Fischel Cancer Center, and the rich information given to us by our study participants, the assistance of our study team. And I didn't get to my final slide about the ALFP to thank the American Cancer Society and the Longaberger family for their support for the American Lymphedema Project. And we are so thankful, too, for our partnerships with our industry invested industry partners in terms of moving forward the lymphedema field. The last slide I had, and it's in your handout, lists our partners, and I just didn't get to that slide. So the work that we do at Missouri is built up on the shoulders of lots of people. We get to be the face of presenting it, Dr. Stewart and I, but so many people are involved in making that happen and in moving forward the research in our field. I want to make sure I say that.
We have time for a couple of questions. We're really right on time. We're going to take a break. Yes, really loud.
Okay, really loud. You were talking about aging, and I was very excited to hear everything you've done. It's very, very great. But when you're talking about the aging process, we all know that lymphedema patients, as they age, other medical problems occur, and they might have another insult to the area where they have lymphedema, for instance, getting a pacemaker or something like that.
Right.
Do you allow for that in your data?
We do. We collect all that information. So in our cohort that we followed for these 7 years, going on to 10 years now, we ask at every visit what medications they take and what other comorbidities they have. If they've had, say, carpal tunnel or a knee replacement or have developed high blood pressure. We have that data. Now, we haven't mined that data yet to look at associations. There are some who have begun to mine the chemotherapeutic agents and the specific treatments for cancer, but there are a few that have looked at the chronic disease coexistence, with lymphedema and its patterns. Those patterns that we saw may be related to a diagnosis of another condition, and no one knows that. Our data simply tells us there's a pattern. And now, as Dr. Stewart says, a human has to explore what those reasons are that there is a pattern or what those associations are.
And just a quick follow-up, so we're going to have a pacemaker or something, what would they say to their cardiologist to, make them aware that they might be insulting the lymphedema issue?
Well, I think it's just as with cancer treatment, we have to do what we need to do to preserve life. So if a pacemaker is indicated for cardiac reasons, I wouldn't decline that because I have lymphedema. But I would let that medical team be aware that I am at risk for lymphedema or I have lymphedema. I would protect my affected side, if possible, from the blood pressure cuff and blood draws and that the IVs during surgery, if possible. Again, if it's a life and death situation, I'd want them to inject me on that side if they couldn't save my life by using the other limb. So I think it's always a matter of a good judgment being made. You may actually, have that lymphedema alert tag on your wrist when you go to surgery. When I go to surgery, I have a Solaris garment on that side to remind them to not use that side.
The cardiologist is really going to be that impressed with the lymphedema tag, so when we realize there are a lot of doctors that
I've got the IV in my
actually know about lymphedema, they're impressed with it.
Well, I think it's a matter of communicating with your healthcare provider, letting them know it's a concern that you have, and together negotiating what the next step is. I think to share your concern about it, to listen to what their feeling is. I think I had a knee replacement. I think my surgeon humored me because I ordered a tribute garment to be on my leg when I woke up from surgery. And he humored me. He didn't think it was necessary, but I know I healed better because I had it. So it was, it's a matter of me saying, this is a concern. I have this information. I know I'm at high risk, so I would like to do this. And he humored me, but he allowed it. He told the medical staff I could have that. So. Yeah, so I think it's really the communication, the trust with your healthcare provider, them recognizing that you're educating yourself about this, you have these concerns, and really being open to what the negotiated step is. Being open to them convincing you or for you being able to convince them and coming to where the middle ground is. And Electra's got an example. You want to share what you shared with me?
Oh, so I needed an IV, and so, actually two, and so they actually used my carotid. They put me under first before they inserted in here, and I've had IVs in my foot because they couldn't get a vein on this side. So you just, two things I hope you take away from Jane's talk. First of all, she's done an amazing job in really furthering the research and what we know about lymphedema and, how we can prevent it. And secondly, from the whole day, I hope you also have understood that you really need to take charge of your health care. It's your body. And the first thing is preserve your life. But you have a say in that, and you really need to be your own advocate because, Jane's a faculty member and nurse. I'm a faculty member. I still, when I come out of surgery, I have my husband in that room because I have to be an advocate. And you have to have somebody there to be your advocate because nobody else will be. It's extremely important. And it's your right to ask things, ask for a tribute. I had mine on when I had surgery 2 years ago. I had mine on and post-op in the hospital. My tribute too. So, you have to learn to take care of yourself. Yeah, last question.
So to that 6 to 12 month opportunity, right?
Right.
In this room, you are speaking to the choir. Anyone here
Yes.
who had a woman who had a 5+5
Uh-huh.
send her straight to where she needs to go, or a man.
Yeah.
So how do you get that message to the healthcare providers who are meeting all of us and wouldn't know 5% if it slapped them in
Well,
the face because they're not doing any surveillance?
That's an excellent point. We work through getting our reports into the literature, sharing them widely with patients and therapists and scientific meetings. But we also have in the background processes underway that build with this. For one is the opportunity to be certified as a breast cancer center, a comprehensive breast center. And to do that, we were able to successfully cause them to be required to have a surveillance plan. Now, there was an agreement on what the surveillance plan for lymphedema would be, but they must have in place a surveillance plan. So now, because of that and the training that's being done so centers can become certified, we're getting a lot of emails and phone calls from New Mexico and every place to say, okay, how can we measure? What do we need to do to measure? Can we have your protocol? Can we follow symptoms? So people are alert because there's a funding stream there and a public relations issue to be certified, to be the first in their city or their region to be certified. So that's happening as an undercurrent here while we're building evidence. You know, I think our work as academic and knowledgeable in this field is to build the evidence so payers will understand, so clinicians will understand, and it's kind of a step-by-step, you know, but you see then breakthroughs. Like, I think the certification for breast centers is a huge breakthrough and an opportunity for us to educate on how to best do the surveillance. And then we have a minimum data set that people can put their data into and to look at outcomes. As we talked in the strategic planning meeting, we need a financial element to that because that will show policymakers and payers that they save money by paying early and surveilling. So it's all of us working together. It's all of us working to do the right thing and get the right information out there. It can't happen overnight, but I do think there's movement. I think we're in a state of movement right now that we can build on.
Right. Thank you, Jane. Thank you very much.